here we have a case where you see the central incisor and the post is literally floating in space. And we're tempted to say, well, this is an easy retreatment, but there's also a periapical lesion. Maybe I'll go in surgically. And when you look down here in the lower left, the root is actually almost 45 degrees to the shape of the crown. And as you can see here, there's a palatal perforation with that post. So if I went in surgically, I would never be able to address that. This would never heal. And if you go in conventionally to retreat this, you want to know ahead of time and explain to the patient about this perforation so that you don't feel like you're backpedaling and saying, oh, by the way, did I tell you that there might have been a perforation? Or, oh, I found a perforation. And this way, you're safe in that you know that you didn't cause this, that this was already existent, and at least you made the patient aware of this. Here's a case where the patient presented with a separated file. When the dentist was attempting to take out the separated file, had a second separated instrument in trying to bypass the first, and sends me the case. Here's my final, but I want to show what the cone beam significance is. The cone beam is your GPS. It's your guidance to how you're going to treat cases like this. Separated files are very, very tricky. And the key to the CBCT right here is that I want to know on which wall these separated files are so that I could work on the inner wall in order to free up space. I know this is counterintuitive to a technique where we always say stay away from the thinner part of the furcation, go on the outer wall. But if you would open up the outer wall, you would end up with a secondary breakage, as possibly the patient, the previous dentist did, separated second file, or there's no room to be able to get that out. So first, I opened up with very thin ultrasonics on the inner wall, using the cone beam as my guidance, able to take out the smaller file, and then I had the larger piece of the file, and I was able to use this loop technique that's invented by my dear friend Yoshi Teriuchi from Japan in order to lasso that bigger piece and take that out. I get a lot of cases sent to me, even from other endodontists, to do apical surgery. And this particular case, the dentist was an older endodontist, didn't do apical surgery, did treatment on this first molar. It looks nice. He sends me a regular film. I took a digital film, but when I take the CBCT, you can see from the shape of this mesial root that there was another mesial buccal canal, known as an MB2 or mesial palatal canal. Now, here is the coronal view of this mesial root. So let's imagine I'm going to do a apical surgery. There's my Lindemann burr that I'm going to cut off 3 millimeters of this mesial buccal root. The problem is at 3 millimeters, I'm addressing the mesial buccal 1, but I'm barely touching the mesial buccal 2. Therefore, I'm going to have to go at a negative angle to get to that mesial buccal 2, and then to correct it so I could see it, flatten it out. Now I'm sacrificing the crown root ratio. Therefore, I'm going to change my treatment plan from an apical surgery to a conventional retreatment. So the cone beam helped to change my treatment plan from originally it was sent to me to do surgery, but instead I'm going to do conservative treatment. I said to the patient, look, I'm probably going to want to do a surgery here, but before we commit to that, you need to go to one of my other offices and have a CT taken. And he has this cone beam taken. And let's first look here. You can see the mandibular canal fairly far away from this mesial root coming over to the mental foramen. But here's the importance. I'm about to show a video, and this is how I scroll through a cone beam. I'm not doing this now. This is how I do in my office, where as I move that blue line here, I'm looking here. And notice that the canal comes here, but then it circles back to the mesial root. And now as I'm scrolling here, looking right here on the cortical bone, that's where the entrance from the mental foramen is. So what's happening is the bundle is coming out through the mental foramen, circling right back to the base of that mesial root. I call a patient, I say, guess what? too dangerous to do surgery. The cone beam has now changed my treatment plan, and I'm going to do a conventional retreatment.